this this special hour, this program, this seminar, or you can say webinar. One of of this chair and co-chair, main idea of this working group is to channelize plasma and to make the plasma protein available to the member countries. We have already, as a group, we have already taken some activities, and these activities to, first is a promotion to making this conversion of the whole blood, because we are mainly working in the developing countries, converting whole blood to the component, that's number one, then quality plasma, then channelizing plasma, and making the plasma proteins available in all countries. And we have got some target countries, and the one is definitely is from Nepal. We are on discussion with Sri Lanka and also with the Indonesia. And thanks to Dr. Tegu, he has joined it. Recently, there are some developments in the field of, atom. We are having actually close collaboration with AABB. We have gotten MOU. So we are working on AABB quality certificate for all ATOM member countries. This is a special product only for ATOM member countries at this moment. And already 6 blood bank has already received this certificate, and another few are already in the line. Now again, we are getting our country so they can achieve this target, getting this certificate. And we are in discussion with WHO how we can do it for our countries. Quality development of the quality of the plasma, ultimately making this plasma protein available for the population living our member countries. I think I have exhausted my time, and thanks to our chair, co-chair of this group, Dr. Anand, Dr. Ranjit, Dr. Sangeeta, and I will fail my duty if I do not mention the name of our coordinator. He is Dr. sorry, that name's Subroto. Is I actually missed your name. Kollan.
Dr. Kalyan.
He is one of the most active coordinator with us. And my special thanks to all the guest speaker from different organizations. I think now we should go ahead with this, our speakers. Let us listen to them and learn from them. And my special request, let us not stop here as a seminar or a webinar. Let us have some sorts of strategy so that we can go together and have this something like a mission, make plasma protein available for this part of the world. Over to you, Sangeeta.
Thank you so much, sir, for your ever encouraging words and motivation to all of us. And now to start with the webinar, I call upon our chair, Dr. Anju Verma. She is the medical director for Rotary Blood Center at Delhi. She has a vast experience in transfusion medicine and has been there as a guiding force for all of us for years together. Over to you, madam, for the chairing and to take forward the webinar.
Good afternoon, everyone. At the outset, I would like to thank Sangeeta and Adam for giving me this opportunity to chair this session, a very important session indeed. That is plasma-derived medicinal products, which plays a major role in healthcare, and it's very crucial for the prophylactic as well as for treatment of many diseases like hemophilia and immune diseases, autoimmune, inflammatory diseases, etc. So I invite Dr. Jan Bult from USA to talk on the impact on global supply of plasma-derived medicinal products, challenges and options during pandemic times. Jan brings 45 years of relevant experience He was the president and CEO of the Global Plasma Protein Therapeutics Association for more than 20 years. And he has made over 200 industry presentations in different parts of the world. Over to you, Dr. Jain, to share your presentation. Over to you, yeah.
I think I need, I need to share my screen, if I can find it. 1 second, there is something going wrong.
You have been made the host and you can share.
Yes, but my screen has changed. I have
Okay.
a problem.
Okay.
I have to try to figure it out what happens here.
Yeah. Take your time.
I have to join again. Okay.
Yes.
Okay.
Yeah.
Okay, there we go. Share screen. Okay, now how do I get this?
What you can see now?
Well, I can see all the pictures, but I'm trying to
Okay,
find.
so now go to share screen.
I have that share
Below
screen.
bottom. Yeah.
Yeah.
Share screen, then open your desktop, and where your presentation is, click on that.
Yeah, but I need to find my desktop. This
Okay.
is the desktop. Can you see it?
Not yet.
Okay. Okay, Ranjit, can you open it for me, please?
You have it, Ranjit, with you?
I have it here, but I sent a copy to Ranjit.
Yeah.
Okay, that's good.
Just give me a second.
Ranjit will do it.
Just give me a second.
Yeah.
Yeah. Give me a second. Yeah, sure.
Yeah, sure.
I'm very sorry, but I seem to have a technical problem. I can't do it from here. This is.
That's okay, Dr. Jain. That's not a problem. Ranjit would do it. Don't worry.
That's why we had to back up.
Yes. Now I'm just doing it.
Yeah, sure. Yes, we got it.
You got the presentation?
Yeah, we can see that, but you have to open the presentation.
Yeah, I opened it. Can you see it now?
So do it, Ranjit, do it on a slideshow.
Okay. Good
Okay.
now?
Yeah, we can. Yes, we can see.
Thank you, Ranjit.
Dr. Jain, you can see it?
I can see it, and I will ask Ranjit to move the slides. So this
Most
is
definitely. Yeah.
okay. Thank you for this invitation, Ranjit, and let me get started. First one. The first slide that I'm going to show you is a declaration of interest, and what you can see there is that after my retirement from PPTA, I've started to work as an independent consultant, and you see here listed the companies that I provided service for as a declaration of interest. Next one, please. When we started to talk about the PDMPs, the first one that we were talking about is the development of albumin. After Second World War II, Edwin Cohn was tasked to develop albumin that was used on a battlefield. And the sad story is that, as you can see, it all started with albumin. Next slide, please. And what we have today it is still albumin because of the terrible things that are happening in Ukraine at the moment. The good thing is that after the interventions, industry as a whole has stepped up to provide aid to Ukraine. And you see here a shipment that was organized by Protea in Amsterdam as humanitarian aid and shipped to Ukraine. And you see here on the right side a picture where the goods, despite all the problems for transportation, have arrived. And it is really heartwarming to see how many industries, how many organizations have stepped up to help the people in Ukraine. Okay, now I am going to start with a few slides from Matthew. Matthew is on the program, so I'm sure that he will later on give you updates, but this is important to set the stage for the discussion of today. As you can see from this forecast, is that the IG market, the immunoglobulin market, will continue to rise. And that is very relevant because the immunoglobulin market is the driver for the volume of plasma that needs to be collected. Next one. If you look at plasma as the starting material for the fractionation, then it can come from two sources. It can come either from recovered plasma, which is the bottom line, or it can come from the source plasma, which is the gray line. The total, the orange line, shows that the volume of plasma has gone up, but the growth is only coming from the source plasma. And I know that last week Matthew gave updated information. I don't want to take that away, so you will hear that later from Matthew. Next one. That is also relevant. This was the situation in 2019, which was the year where the highest number of collections took place in the United States. You can see that most of the plasma that is used in the world is coming from the United States. 2/3 is coming from the United States. And if you look at the Asia and Pacific part, it's 18%. Most of it is in China. I will talk later on about things that need to be done here. So this is just to set the stage about what's happening with collections. So the question was the impact of pandemic and what the consequences are. Next slide, please. So what you see is that 2/3 of the plasma for fractionation is coming from the United States. And if you look here at this graph, you can see that for year after year, that the volume of plasma that was collected went up without any dramatic change. The first dramatic change is in the year 2020, where you can see that the number of collections went down. You see in the blue column the actual number of collections, and in the small box you see the number of collection centers that were contributing to these numbers. So if you then look at the next slide and you start to talk about what the COVID impact was on the collections, then you will see that in 2019, we had the highest number of collections in the United States, which was about 53 million donations. In 2020, this went down with 20.7% to a total of 42 million donations, which means about the level that we had in 2017. So in other words, the collection level were at that moment 3 to 4 years behind what they were supposed to be. And the reasons for the reductions, they're all self-explanatory, but of course the infections played an enormous role, the travel restrictions, the social distancing, which meant that in the collection centers, arrangements had to be made to make sure that the donor beds were on sufficient distance from each other. The waiting rooms had to be changed, so you could not have too many people in the waiting room. You saw that more and more people were working remotely, colleges and universities were closed, and last but not least, there was an economic stimulus package. As you well know, donors in the United States receive a compensation for their donation, and the economic stimulus package that was given was in many cases much, much higher than what people were receiving as regular income. So therefore, the stimulus to do additional stuff was not there. And you combine that with all the other restrictions, it's no wonder that the number of donations dropped significantly. Okay, so then the question is, what about 2021? Is there any change? Well, we saw that the frequency of donations was less than in 2020 for the reasons that I just mentioned, despite the fact that more and more centers have been opened. If you compare 2021 to 2019, you will see that about 200 more centers were opened in the United States with an average of 2 per week. But at the same time, the average volume of plasma collected in the centers went down. So that means the efficiency was clearly impacted. Yes, we have seen the start of the vaccination, and everybody was hopeful that this would be the beginning of a return of donors. And in May, we saw first signs of recovery, but the year was not over yet. A new obstacle arose in June. Next slide. In this map, I think this is also coming, if I'm correct, from Market Research Bureau. You see a map of with locations of many centers in the United States. One thing that is very important is that along the border between the United States and Mexico, there are many centers. About 50 plus centers are located along the Mexican border. And what had happened is that Mexican citizens were able to cross the border with a visa that gives restricted access to the United States. But with that visa, they were able to cross the border, donate plasma, receive a compensation, and with that money, they were able to buy goods in the United States that they were unable to buy in Mexico. So this was an enormous important factor for the donors from Mexico. Now, next slide. So this changed. So I already told you there are 50 plus centers along the border area. And the important thing is that these centers in average are larger and collect higher averages of volume. It's also interesting to note that if you look at the viral marker rates from the donors in these centers, they traditionally have been about half of what you find as an average in the United States. So there was absolutely no concern with regard to the safety aspects of the donors, because this was many times a question that was asked. I told you they could cross the border with this B1, B2 visa, but then the Customs and Border Agency changed the policy. One of the conditions for crossing the border with this visa is that you are not allowed, this is not a work permit, so you're not allowed to make earnings in the United States. And suddenly the agency considered the compensation that donors received as an earning. And for that reason, the donors were no longer allowed to cross the border for the purpose of donation. And that has a significant impact of the volume of plasma that is collected. The estimate in the beginning was about 9%. The affected companies, there were 4 companies that were affected by it. They started a legal case, and that legal case has been dismissed. So there is no clear indication that this policy will change again very soon. So next slide. If you look now in a little bit more details about the collection, then you see the following. This is a graph of the US collections in the last 4 years, but then on a monthly basis. And if you look at the orange column, that was 2019. That was the year where we had the highest number of collections. When you look at the next one, the gray column, then you will see that in the first 3-month quarter of 2020, it was still following, let's say, the regular pattern, but then the drop occurred. You can see that with April, for the first time, you saw a significant reduction compared to 2019. And that has been the case for the remainder of the year. If you then go to 2021, and I apologize for the typo there, the dark blue column, you still see that it is below what we found in 2019, though it seems that the collections are going up, and my estimate for this year is that we most likely will end up somewhere between 43 and 44 million donations for this year. And if that is the case, that brings you between the levels of 2017 and 18. So in other words, still behind of what it was. So the question then becomes, what is the impact of these reduced collections, and how is this going to impact the availability of products? So next slide. So what I saw happening was that the collections reduced with 21%, but at the same time, I saw in 2020 that the distribution of immunoglobulins in the United States increased with 13%. And so if you have a reduction of plasma, and at the same time you see an increase in supply, then it has to come from somewhere. And that was the same time when many countries, and I have listed here Brazil, but there are many others, they notified us of a supply disruption in 2021. Some companies withdrew from some of the European countries. You could see that the interest in tenders was reduced. And it was clear to everybody that the dependence on the United States plasma became disproportionate. As we have seen from the very first slide, that the volume of recovered plasma is totally insufficient to meet the growing clinical demand. And it is also clear that multiple regions who don't collect sufficient plasma to meet their own needs. And that is true for Europe, Latin America, Asia, and Africa, almost the entire world. And one of the initiatives that we are aware of is that in Europe, the European Commission is working on a revision of the blood tissue and cell directive. And in that directive, there's going to be a lot of language emphasizing the need to collect more plasma through plasmapheresis. So now, as I told you, next slide, you could see that there were signals, and this is just a picture of a few countries where you could see that there were supply disruptions, and this list is absolutely incomplete. There are many more countries that are facing problems at this moment. So I think this has become a clear wake-up call for many countries. Next slide. So the question then is, what's happening? Because if we see this reduction in supply and availability of plasma, why is it then that the supply in the United States continued to go up as if nothing had happened? Well, that tells you that is just a matter of priority for the industry, what to do with the products. And it was clear that knowing that the plasma is coming from the United States being the biggest market for immunoglobulins, about half of the immunoglobulin supply is consumed in the United States. It was clear that the United States was not going to suffer from that. However, if you go to the next slide, and I apologize for the quality of the slide, but it's the best I can do. This is a graph of the immunoglobulin supply in North America. And the blue line is very, as you can see, these are the monthly data. But if you look at the purple line, which is the 12 months average, then you see for the first time in over 25 years that the actual supply, the actual distribution of immunoglobulins in the United States is declining. And then you can ask, why is that? Is that because the demand is going down? Or is it that the availability is going down? It is, I think that's too soon to tell, but it is clear that the availability of immunoglobulins in the United States is also reducing. So, next slide. A very small picture about the situation in Europe, where you can see, and I don't want to go into too much detail, I'm sure that Matthew can say much more about it in his part, is that there is no growth in Europe. I think that's the most important message. And it's very interesting to see what the revision of the blood, tissue, and cell directive is going to do, and whether that will have an impact on the ability of countries to collect more plasma. Now, we have to realize that it is possible, because I go to the next slide. As I've said, I provide services in Ukraine, and so that gives me an opportunity to use this as an example. When you look at the map here, forget all the politics right now, but if you look at the map, you can see a couple of areas, the red ones, where existing plasma collection activities were taking place. The green ones is the ones where expansion is expected. So if you go to the next one, and you see what happens in this country that basically started from scratch, then you can see that there is really a very interesting development once you set up a system with a network of collection centers that leads to the collection of plasma. And you can see this started with low numbers. In the year 2021, it was 170,000 liters. And for 2022, it was estimated to go up with another 100,000. Of course, that is out of the window now. All the plasma collection centers in Ukraine are closed. The only collection that's taking place right now is whole blood and components. But the only reason I want to show this here is that it is possible if you really are focused and want to make things happen to do it. And even when you look at the monthly development, next slide, you can see it's very consistent. If you look what happened in 2021, look at a very consistent development of plasma collection. And of course, it doesn't come by itself. Next one, you have to develop an enormous amount of material and promotion. It was all happening. So again, I would really encourage countries that are interested in collecting plasma, don't give up. It is possible, but you have to devote the right amount of resources to do so. So now, what are the challenges and opportunities? Next one, please. Next one. Last week, the previous one. Yeah, last week there was a meeting in Amsterdam organized by IPFA and EBA, and one of the speakers was Paul Strengers, and he showed some interesting pictures about the development of industry in Europe. And if you see on the far left, this was a situation which was many years ago, where you had a multiple of countries with existing fractionation capacities. But then if you go to the middle one, you can see there is already consolidation taking place. And if you go to the right one, you can see it's even more consolidated. So what you have right now, you have basically three big companies, CSL, Takeda, and Grifols, and you have a number of smaller companies that are providing the market as well. So why is that? Next one. It has become clear that if you want to have successful fractionation, then you really need to look at the economics of fractionation. And that means you need to be able to produce multiple products with a revenue in order to have sufficient funding to pay for the complex technology and the infrastructure. I don't want to go too much in detail here, but it is clear that if you are able to produce multiple products from your plasma, you have the highest revenue. However, if you look at the right side, if you're only going to be able to produce one or two products out of the plasma, which in the most cases will be immunoglobulins and albumin, it's going to be much more difficult to pay for the whole operation. So the economics of fractionation really need to be considered very well. And that was, next one, that was one of the reasons why the WHO created a task force to start looking at what can be done for low and middle income countries that are facing these challenges, not having enough plasma in their own country, relying on import of products, where at the same time they want to do more to be more self-sufficient for these products. And as you can see here, two ways how this could be done. It's either by using recovered plasma or you have your source plasma. And the problem is that in many countries, recovered plasma is wasted because it doesn't meet the quality criteria that are set by the manufacturing industry. So one of the goals was, what can be done to make sure that the waste of recovered plasma is reduced and that countries are going to be able to set up their own systems. Next one. So in this guidance document from the WHO, they developed a step-by-step approach. And it basically comes down to a couple of very basic issues. One is, know what your needs are. What do you need in the country? What is the number of patients that you want to serve? What is the amount of products that are required? Do you have to produce all products, or can you work with less? Once you know what your need is, the next thing that you're going to do is you're going to see, how much plasma do I have available for these products? And do I have a national program for collection? Do I have the right procedures? Do we comply with all the GMP requirements? One thing is clear, if you start thinking about establishing your own plant, yes, I am aware that some countries try to start with 100,000 liter plant, but I can tell you that's extremely expensive. And the likelihood that you're going to succeed in the long run is highly problematic. So the more you can collect, the better it is. So once you have the volumes that you think you can do, you need to make sure that you have all the quality requirements met, that you meet the requirements, the regulatory requirements, the quality and safety requirements. And if that is all in place, and then we come to the last one, if you have the economic consideration, then you can start thinking about having your own plant in the country. But if you do so, you have to realize that it's going to be a big capital investment, that the cost for plasma collection is increasing. You definitely need strong leadership, and do not underestimate the training that is necessary for all the technical personnel. So I'm not saying you can't do it. It can be done, but it requires focus, commitment, and resources. Next one. So my conclusions are, it's very important to differentiate between whole blood and plasma. For the production of PDMPs, you need plasma, and collecting whole blood for the purpose of creating plasma for fractionation doesn't make sense. You need to have a good program to take care of your need for whole blood and components. If you have recovered plasma available after that, fantastic. But if the focus is on the production of PDMPs, you really need to start thinking about plasmapheresis as the way to collect this plasma, because the future clinical need, and that is the driver for plasma, it can only be met through plasmapheresis. I hope that everybody agrees that steps need to be taken to improve their own collection and reduce the dependence on US plasma collection. Now, I know this is a very sensitive topic, and each country has the right to make their own decisions, and some countries absolutely do not want to talk about compensation, but our experience is that only countries where compensation is approved, they will show demonstrable increases in plasma collection. I don't want to push this issue. I don't want to force it. I just want to bring it to your attention so that it's not off the radar. I mentioned to you that the European Commission is reviewing its current directive, and it's expected that in May, the new directive will be proposed, and then after the necessary parliamentary steps, it will most likely be accepted within 12 to 24 months. If you are serious about setting up your own plasma collection, then I would definitely encourage you to use the expertise of the large plasma collection organizations. And I hope that with this picture, I was able to give you a total picture, what the drivers are for the collection, why the problems occurred during the pandemic, what needs to be done to reduce the dependence on US collections, and encourage the countries to develop their own systems and use the WHO guidance that was developed as a practical tool. And I hope that this is meeting your expectations. Thank you for your attention.
Thank you, Dr. Jan, for your very insightful presentation. And I think the scenario was same in all parts of the world, less collection, and the reasons were also the same in the last 2 years. Now, take-home message is that we should continue, we should not give up, keep collecting, try and keep collecting plasma, but maintain the quality so that there is no shortage of product for the patients the country requires. Taking it forward, now I invite Dr. Ranjit Ajmani, alumni of IIT Mumbai, visiting fellow at the National Institute of Health and Johns Hopkins Medical Institutions, USA. He has been the pioneer and instrumental figure in the field of plasma protein therapy in India. Dr. Ajmani is a prolific speaker and has addressed several seminars and conferences within and outside India. It is always a pleasure to hear him. Currently, he is the CEO of the company Plasmed in India. So he'll be speaking on status of plasma product and its accessibility in India. Over to you, Dr. Ajmani.
Thank you, Dr. Verma. I'll just give me a second. I'll share the screen. Is my screen visible?
Yeah.
Yes, it is.
Slideshow.
But put it on. Yeah. Now it is, yes.
All right. Thank you very much, for giving me this opportunity to share about what's happening in India. And I'll take through journey and status both of plasma fractionation in India. And what Jen has said, and I've spoken at various forums, the setting up a plasma fractionation program in any country is quite challenging. And when I returned back from the US in early 2000, and now it is almost 22 years I have come back. And the scene has changed, but how much has it changed? How was the journey? Let me share that experience with you. So in 1990, if you see, 1989, there was a plasma fractionation center called as NPFC, which was established in Mumbai at KM Hospital with the Swedish grant, and it was just 10,000 liter plasma fractionation center based on the chromatography model. And it was considered that probably if this model works well, this can be replicated and this can be expanded, etc. But unfortunately, for a variety of reasons, first of all, the major thing what Yen has mentioned, the plasma, because at that point in time, India didn't have any plasma collection program where the plasma can be properly channelized, collected from various blood banks. And even very few number of blood banks were making the component. So the plasma collection was very, very limited. And to best of my knowledge, this center could never fractionate more than 8,500 liter of plasma on annual basis. So this was a major handicap. And again, it was a chromatography based model. It was set up on the 7th floor of a building. And these logistic impractical reasons finally led to closure of the center in 2002 summer. And unfortunately, at that point in time, then there was no plasma fractionation facility around 2000. Now it was all 100% import dependent, whether it is in the form of the bulk or the finished formulation, or in the form of paste. Then the non-availability of safe plasma was the major challenge for any company, any organization to take this agenda forward. Then also, if you look from the patient point of view, the rate of diagnosis was very, very poor. Today in country like India, the rate of hemophilia diagnosis is maybe still in the single digit, maybe 9%, but at that point in time, it was about 3 to 4%. PID, still we can see that in India, there are hardly 100 patients on the registry of PID. And one can imagine the numbers are going to be multiples and multiples. And these are the numbers which are really practically negligible if you look from the statistical occurrence of disease or epidemiological pattern. Also, there was an outdated delivery system of these products, which means the maintenance of cold chain and how to it reaches out to the rural setting, whether the tenders can be done or cannot be done, etc. Then undefined regulatory system. The regulatory system was extremely primitive at that point in time. And as I said, even 1 liter plasma collection was not permitted. And this was the case until 2004. And I remember, in 2004, I had a target of collecting 10,000 liter plasma in India. And unfortunately, I wasn't successful. I could only collect 8,500 liter of plasma from more than 1 billion people. And this was the reality of the time. The patient groups were really either not very well organized, but they were practically inactive for a variety of reasons. And of course, the major issue was public health policies. And still this question remains unattended. That's why I put a question mark, that the public health policies have to improve to increase the access and affordability of these products in India. And no public supply. At that point in time, there were hardly any tenders coming from the government setup, which means if you look very genuinely, all the plasma products, first they were imported, which means if there's any fluctuation in the dollar or euro, it will have a direct impact on the price of the product. Second, once it is available, most of the time it was not available. But even if it is available, there was no tender, which means people have to buy, patients have to buy from their pocket, because in India, the insurance cover at that point in time was less than 2 to 3%. And most of these patients have to buy from their own pocket. So one can imagine the Indian average salary and buying these products was practically impossible. So at the end, it was affecting the quality of life of patients. And also, many of the patients were remain undiagnosed and they died absolutely silent death for non-availability of these products. But as we are talking in 2022, there are 4 plasma fractionation facilities which have come in the last 22 years. And is it that an impressive number? The question can be debated on either sides. A country of about 1.4 billion people And the total capacity of these 4 fractionation facility will still be less than 1 million liter of plasma per year. So I think it is a big question to figure it out, how to increase this 4 into, I don't know the number part of it, but increase the total capacity of plasma fractionation is very critical part. India is still 55% import dependent if you look from various perspectives. Of course, it's a product dependent. So the only 700,000 liter plasma is available for the fractionation. And this is only from the recovered source because the law of the land doesn't allow collection of plasma. The pheresis plasma for the fractionation purposes. The rate of diagnosis has certainly improved, but has it reached to a respectable level? Answer is definitely no. A lot needs to be done on this account. The change in regulation, of course, the plasma policy has come from a huge struggle when we started in 2003, and eventually it saw the light of the day in 2014. It was a long 11 years of journey to do the lobbying, to make the policy maker understand what is the necessity of it, and so on and so forth. The testing methods of plasma product, because by Indian law, every product which is imported undergoes the testing of product every batch. So certain methods were quite outdated and still they are outdated. So they have changed certain methods, but is it enough? Answer is no. A lot needs to be done on that account. In the Indian pharmacopoeia, there are very limited monographs and they need to be changed from the perspective of changing the testing method, which has evolved over a period of time. And of course, now the NACO has dissolved and it's no more active, but a lot of work has to happen on the plasma collection, on the testing protocols of the product, etc., etc. Again, it's outdated delivery system in many of the states. The tenders are very, I would say, outdated fashion, which means every year there will be a tender of, let's say, factor 8. And one knows that every year you cannot change the brand, you cannot change the company because it has a effect on the quality of life of patients. So I think it all needs to be done at a much federal level, central level, to make sure the delivery system is better. Patient groups need to, now there are 5 patient groups for hemophilia, PID, etc. But is that enough? Answer is no. The Orphan Drug Act did come in existence, but it is more focused on the metabolic disorder rather than anything else. So this also needs to be looked into it. Again, as I said, public health policy has definitely changed, it has improved, but is it up to some respectable stage? Answer is no. There is a tremendous growth, let's say in the purchase of factor 8. There are like 500% growth, but is that enough? Answer is no, because only the rate of diagnosis is less than 10%. So a lot of people need to get diagnosed, they need to get the treatment, etc. So I think this still remains an unanswered question. So if you look overall situation, the rate of diagnosis is very poor. If you look, the low clinical awareness lies even in the blood bank, and what Ian has said that, the blood is collected, but even not all the blood which is collected gets converted into plasma, and still there's a use of whole blood. So clinical awareness on the component therapy is very important. Of course, there's a low blood collection in India, and only the 40 to 45% of blood gets it componentized, which means 60% of blood is still used as a whole blood. And there's a domestic plasma fractionation capacity is very low at this point in time. The affordability, the medical coverage is where insurance coverage is very low. Public health policies need to get changed so that the out-of-pocket expense, it's just not possible. What happened in the COVID situation? There is at least 20 to 30% decrease in the blood collection, and so is reflected into plasma globally. And same thing has happened in India. So there's a decrease in plasma collection at the global level, and its impact will be observed everywhere. This has to be 22. I'm sorry for this mistake. And its impact will be seen from the point of view of availability of products, pricing, and regulatory. And the reason being, many of the countries, now the usages of IVIG has gone up, the usages of albumin has gone up, and now the product is not available as it used to be earlier. Since the product is in scarcity, the pricing is an issue. And in certain countries, the restrictions have come that you first need to meet the demand of the country, and then only you can sell the products in the other markets. So that will also come. So having this local base of plasma and product is very important. And now where Canada and UK, what Jan has projected in the slide, they are thinking of working on the program of plasma collection in the country. So blood and plasma, it's, if you look, it's a national resource, it's scarce one, it's a very critical, and it is finite. And it has a huge financial implication if you look from the health point of view, which means the usages of blood and plasma needs to be very, very carefully calibrated. There's a geographical limitations also, which means the blood cannot cross like the countries, but plasma can. And probably this needs to be re-emphasized that the plasma is very, very important from the plasma product point of view. It saved millions of lives. And if you would have seen the various conferences, maybe 20 years back, let's say an hemophilia meeting, where you will find many people on the crutches or on the wheelchair. But today, if somebody attends this meeting, it's a very positive feeling that you will find hardly anyone on the wheelchair or crutches or using any other support. And this is what has happened. It has not only saved the lives, it has improved the quality of life of patients who need this plasma product. And there's no substitute for some of these products, which means this plasma products are going to be in demand for time to come. And so therefore judicious use of plasma and plasma product is scientific, clinical, and economic an obligation for any country or region. And that is where we are talking. There's a donation of blood and plasma both. And if you're donating the blood, all the blood units should get converted into the component therapy. And at the end, each drop of plasma should get fractionated. But country like India, which is still 50-55% import dependent, the affordability is a huge challenge because India is a very, very price sensitive market. Sometimes the safety issues are the concern, like what happened during COVID time. All the supplies were disrupted. So there are safety consideration. And again, because of these situations, you can see the erratic supply. India has so much of short supply of many of the product in the current situation. Then cross-border restriction can come at any given point in time under the socio-political difficulty situation. And if we don't do it, how are we going to upgrade the Indian blood banking system where we collect the recovered plasma? And we must make use of Indian plasma. This will help us in saving a lot of foreign exchange. And probably we can think of self-sufficiency once we start converting every drop of the blood into components and use that plasma along with the plasmapheresis program, which India must think about. So I think what happened during the pre and during COVID time and the post-COVID time, India collects about 11 million units of blood every single year. Is this enough? So there are many, many studies conducted. Even if you go by WHO now, they say at least 1% people should donate the blood. So even going by that now, this 11 should be 14, but still there is a deficit of about 3 million units. But is this enough? So there are multiple studies conducted and the numbers have come very astronomical, maybe more than double because of the treatment regime and the kind of treatment protocols which is followed in India, and along with the medical tourism which India attracts. So demand of the blood is in India is very, very high, and someone needs to look into it more carefully. And during the COVID time, there's a decline of 30 to 40% of the blood collection. And this is quite a difficult situation. So going ahead, I think what Ian has also said, the mapping and evaluation, availability of plasma product, gap analysis need to be done product wise. How much albumin is needed, how much IVIG is needed, etc., etc. Alongside with it, we must also do how much is the plasma available so that we can think about how to work on the recovered plasma and how do we deal with the source plasma collection program. The safety profile of plasma from epidemiological perspective is very, very important, considering the fact that these products undergo a very stringent viral inactivation protocol, and it starts from the plasma collection. So there's a lot of work need to be done on the profiling of plasma donors. Then utilization of plasma by setting up plasma fractionation plant in India or contract fractionation, whichever way it works. But I guess country like India cannot depend on contract fractionation model because India has 1.4 billion people and it needs plasma collection program, plasma fractionation program at its own. And of course, the financial consideration is very, very important. These projects are very capital intensive. They take a very long to set up the program. So the country or the corporates and the government should be ready to work on it. And patient groups have to play a very important active role in it. And change in the policy for better access and early diagnosis is the way to go forward. And I think we must take learning from other countries for creating sustainable models of plasma fractionation, plasma collection program, accessibility, affordability. I think these are very important learnings which we must take. We really don't need to reinvent the wheels. And I just want to project this slide in its totality. This was in 1965 when Martin Luther King has said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And if you see in what has happened in 21, the richest countries are getting 30 times faster vaccinated than lower income countries. And this gap is very unfair. So I think if one looks at it very, very carefully, this is what is the global scene which emerges, not only in one case in overall healthcare delivery system, which probably gives us a message that each country or region should work on their healthcare agenda, figure out what are the most sustainable model, how to work around it, whether it is a plasma product or vaccine. But since we are talking on the plasma product, and we already know there's a huge gap between demand and supply, availability of plasma and fractionation capacity. So I think we need to work on this agenda very, very carefully. And though India started working on it in a very ugly, caterpillar, but I think its journey has begun and probably one day it will translate. It will look beautiful butterfly. So I think with this, I'll rest my case. Thank you.
Thank you, Dr. Ajmani, for a very good presentation. Thanks for sharing the data, highlighting the obstacles encountered over the years in our country and the way forward. Still, there's lots to be done as suggested by you, and we should be hopeful.
That's right.
Thank you.
Thank
Now
you.
I invite Dr. Kalyan Roy. He is a clinical staff in transfusion medicine unit at Square Hospital, Dhaka. He has done diploma in blood group serology and transfusion from Bangabandhu Sheikh Mujib Medical University and has 8 years of working experience on transfusion medicine and 2 years of teaching experience. He is a member of various organizations and he'll be talking on status of plasma products and its accessibility in Bangladesh. I welcome you, Dr. Kalyan. Please go ahead with your presentation.
Thank you, Dr. Verma. Am I audible to all?
Yes, you are. Kalyan, you are. Yep.
Since my screen is visible.
Yes, it is.
Okay. Thank you very much. Very good morning and good afternoon, everyone. And it's a privilege for me to be here and to present about the current situation of our country regarding the plasma products and its accessibility. So this is the overview of my presentation. It has got basically two parts. One is the introductory and the basic BTS system in our country, and the main topic, the PDMPs we need. So officially, Bangladesh is known as People's Republic of Bangladesh, and it's a country in South Asia, and we are the 8th most populous country in the world. Current population is more than 167 million, and life expectancy at birth and both sexes are 73.6 years. The age structure, 15 to 64 years, are 67.6%. HIV/AIDS prevalence rate is less than 0.01%. And in 2020, GDP was 324 billion USD, and the growth rate of GDP was more than 7.28%. So this is the blood transfusion service history. The blood transfusion service started in Bangladesh in 1950, and it is run by the law framed by the Ministry of Health. Bangladesh NCBT was established in 1976, and restructuring of the BTS began in 2000, and legislation on Safe Blood Transfusion Act 2002 by the Parliament on April 2002, and National Blood Policy published on November 2013. The structure of the BTS in our system, we have got two sectors. One is the government sector and another one is the private sector. And in the government sector, we have 247 centers, and in private sector, 145 centers. So let's see about the donation status in the last few years, like 2018 to 2019, we had got a donation of 974,000 units of blood, and we have basically two types of donors. One is the replacement blood donor, or blood donation from the relatives, and the another one is the VNRD, or the voluntary non-remunerated blood donors. And on the right-hand side, we can see the percentage of the male versus female donors. So the blood component status on the same year, we can see that there was 70% donation of the whole blood, and 30% did we did a componentization of the blood products, and we did it in to RCC, FFP, platelet concentrates, PRP, and cryo. So the TTI screening status of Bangladesh. The TTI screening is done mostly on ICT method, and only in some centers, screening is done by ELISA or CLIA method. And Bangladesh maintains very low prevalence, less than 1% of the TTI markers. Apheresis and blood component therapy, as I have mentioned before, that we have 42 centers which provide componentization, or which has got the component facilities, and the apheresis facilities has got 52 centers, and where we can perform platelet apheresis, plasma pheresis, therapeutic plasma exchange in different diseases, stem cell pheresis, erythrocytopheresis, leukopheresis, and therapeutic red cell exchange. Regarding surplus plasma, though there is no exact data on surplus plasma we have annually, but as only 42 centers have component preparation facilities, rest of the BTS are unable to preserve these huge amount of FFP. So we can assume that a huge amount of FFP we have to destroy or discard. And the table showing 785 units of plasma discarded in 3 years in a tertiary hospital where the FFP storage facilities are also available. So now I'd like to take you to the zone of iceberg. As Dr. Ranjit also mentioned in his presentation, that there is a lack of diagnosis or proper diagnosis of many of the diseases in India, and even also in our country lies on. So we can call it as an iceberg. It is estimated that more than 14,000 males are currently living with hemophilia in Bangladesh. Over 400 children are born with hemophilia every year in Bangladesh. Only 15% of patients with hemophilia are registered to the World Federation of Hemophilia, and over 82% of these registered cases belong to hemophilia A, and remaining are the hemophilia B. And it's regrettable that a nationwide registry for patients with hemophilia is currently absent in Bangladesh. Only 10% of the patients with hemophilia can afford standard treatment. The average per capita consumption of factor 8 and factor 9 is well below the standard in Bangladesh. The incidence of burn injuries is frighteningly high in Bangladesh, and more than 3,000 people die from burn injuries per year. And Bangladesh harbors about 8 million of chronic HBV and hepatitis C infected people. The frequency of Rh negative population is 2.6%. We got 256 cases of rabies in between 2013 to 2015. And TPE as an adjunct treatment of GBS was conducted in 97 patients in between 2017 to 2021 in BSMMU. And in the capital, few corporate hospitals regularly perform TP in different cases using the 5% human albumin as replacement fluid. So these PDMPs, where do we get from these PDMPs? We still do not have any plasma fractionation center. Neither we are going for any toll fractionation. So unfortunately, the life-saving PDMPs has to be imported. And Bangladesh spends almost 100 million Bangladeshi currency per year for these PDMPs. So the PDMPs we have to import are human albumin, intravenous immunoglobulin G, hepatitis B immunoglobulins, anti-D immunoglobulin, coagulation factor 8 concentrate, coagulation factor 9 concentrate, rabies vaccine, and much more. And clotting factors donated by World Federation of Hemophilia through its humanitarian aid program. And between 2015 to 2019, a huge amount of factor 8 and factor 9 concentrate were donated in our country. The challenges we are facing right now for having a fractionation policy: inadequate voluntary blood donors, lack of estimation of the need of the PDMPs, lack of demand from the physicians to use the component, lack of component facilities in tertiary and district level hospitals, and lack of skilled manpower, regulatory, legislative issues, and lack of GMP and QC management. But there is a light of hope that one of the most powerful equipment of Bangladesh is her population, and they are potential plasma donors. So soon, the government of Bangladesh will take initiatives to take this sector further more improvement. So in conclusion, I'd like to say that human plasma is a strategic resource that can be processed into more than 30 unique therapeutic proteins used to treat various disorders and diseases. The WHO model list of essential medicines includes several PDMPs, and the supply of the PDMPs in low middle income country is profoundly deficient relative to patient needs. Global shortages and the costs of PDMPs resulting in increased mortality, morbidity, and higher healthcare expenses. So to increase access of PDMPs through fractionation of domestically produced plasma in a low middle income country should first reinforce domestic infrastructures to collect blood or plasma from voluntary non-remunerated blood donors, and to ensure its quality and safety through implementation of good manufacturing practice and effective regulatory oversight. So this is all from me, and these are my references, and thank you very much for your kind listening.
Thank you, Dr. Kalyan, for sharing data and the status of plasma products in your country. As the time is short, I would like to ask Dr. Sangeeta to continue with the next session. Sangeeta, please take over.
Thank you so much, ma'am, and for being there as a chair for us. And now, because the time actually is less, so I now switch on to the session, next session of panel discussion. And the panel discussion is on how to improve the access of PDMPs in the developing countries. And we have a panel of very elite speakers with us, and I would like to introduce them one by one. We have with us Mr. Matthews Hodgko, and Matthews is the president of the Marketing Research Bureau since January 20, and is a noted global expert about the plasma industry. And in his capacity as president, he is responsible for all aspects of running the company, whose aim is to provide accurate data and forecast to the plasma collection. So as he is on to such an important position, Matthews will be able to put up a lot for us in this particular panel discussion. Then we have with us Dr. Tegu, and Teguh Triano, and he is from Indonesia, and he is onto a lot many important positions. He have been as the advisory board of the blood regulatory availability and safety with WHO, National Committee for Blood Services, National Committee of Patient Safety, Department of Clinical Pathology and Lab Medicine, Hospital Blood Transfusion Services. So he has held many important positions, and for us, he's important, and he's as a member of ATOM, National Committee of Patient Safety, and he comes with all such experience for us today, and it will be a very good interactive session with Teguh as well. And then we have Mr. David Stubbings. David has long and broad scientific and industry experience. He worked for the Natal Institute of Immunology until '94 when he joined the Natal Bioproducts Institute, later to become the National Bioproducts Institute. And David joined as NBI as the head of products and services, became the quality control manager, leading on the role of quality management and part of NBI senior management team. And he was appointed as the CEO by the board of directors in April 2012. So we would have a good session with David in the team with us. And last but not the least, we have with us Dr. Manita. Can I have her? Yes. So Dr. Manita Rajkarnikar is not a new face for ATOM. She has been associated with us for long. And right now, she's a medical director, Nepal Red Cross Society. And with her qualifications, she is a doctor of general medicine from Comenius University, Czechoslovakia, since 2002, working in Nepal Red Cross. And with the positions that she has gone through as senior deputy medical officer, chief deputy director, and right now she's the director. And she's a member of Nepal Medical Association, vice president of ATOM International, and she is also the president for the Nepal chapter of ATOM. And we all know all the deliberations that we heard just now. We all know that the medical treatment that's right now being there relies more on the components rather than on the use of whole blood. And while these components are being prepared, we all understand that the surplus plasma comes out. But as it was pointed by Dr. Jan also, that the plasma that is coming out as surplus is not of the required quality that is actually required for plasma fractionation. So investing in this well-organized, stably financed and appropriately regulated national blood system, which is capable of generating quality plasma suitable for fractionation, is a crucial incremental step towards eventual sufficiency of the PDMPs. And I would like all my elite panel members who are here with us to discuss about these points of plasma supply, plasma fractionation, regulatory challenges, and the contract fractionation. So my first question, it goes to Matthews. And this question remains actually same for all of the panelists, is how plasma availability has impacted during the COVID times and how it is going to play out in times to come. Over to you, Matthews.
All right, thank you, Dr. Sangeeta. Hopefully everyone can hear. I think that some of the information about what's affected in the past was presented very well by our presenters, including Jan Bolt and Ranjit and Dr. Kalin. But just to kind of talk about how will it play out going forward, I think if we look at the global industry, 2/3 of the plasma comes from the United States. And so that country, as Jan had mentioned, they have actually almost 240 new plasma collection centers have been built in the last 2 years and 3 months. So 240 new centers. So that is going to help a lot this year for the industry to collect more plasma than during the COVID year. So I predict this year there will be more plasma collected in the United States than any previous year. So it'll be a return to growth. That may not happen if there's a new COVID strain, but assuming that there isn't, anything too bad that happens the rest of the year, I think that will happen. So that will mean that eventually, let's say at the end of this year or the beginning of next year, there should be a little bit more products made from that plasma and should support supply a little. The challenge is that it's probably much more expensive. Inflation is high in the United States. Donor compensation is higher. So the cost of collecting plasma has risen and it is not expected to go down. So therefore, plasma products will probably increase in price. They will continue to get more expensive. So maybe not factor products, but certainly immunoglobulins and possibly albumin. So I think that will affect European and Asian patients. So there should be more availability, but affordability will continue to be a big challenge. But I think the tenders, there should be more companies able to bid in tenders next year because they will have more supply. Again, at what prices? I would predict for IG higher, but the other products maybe not higher.
Yeah. So the similar question goes to Tegu Triano also from Indonesia, because as Matthew said, though the collection is going to increase, but the affordability in terms of the price and all would be a big question for our areas. So how about it, Dr. Tegu?
Thank you, Dr. Sangeta, for the questions. And first, thank you also for all speakers for what have been presented. It gives us a global views of plasma fractionation. I like to say that Indonesia is one a country like Bangladesh. I think that we have no fractionation program nationally. So we are depending on 100% of import of plasma products. So especially during the COVID time, we actually this program is on progress actually, but because of the COVID, so we Indonesia then postponed this program to 2 or 3 years, next 2 or 3 years. So we think that we have same problem with any countries in the world that the donors, I mean the non-remunerated donors have been decreased and could be in 30 or 40%. So nationally, so we make that we mean that it means that plasma availability also could be decreased. I mean in recovered plasma. But I just like to say that in other way or in other hand that this pandemic have given us the other experience how to collect the plasma. It means that how then we can collect our national CCP program in Indonesia. So we have first we have experience to collect the plasma, and the other thing also we have more and more apheresis machines around the country. So we think that it will be support us to make or to perform our national fractionation plasma program in the next years. I think it is. Thank you, Dr. Sangeta.
Yeah, that is nice. That if we can come up with some plasma pheresis program also instead of the surplus plasma coming from whole blood, that would be also a very good initiative coming from all of us who are sitting here and can put forward for a plasma pheresis program also for the coming up to the needs for PDMPs in our areas. So can I see David there? But David is muted. Is David around?
He's still there.
Yeah. So David, I have a question to you. I thought you've muted and gone away. So I have a question for you, David. How plasma fractionation program should be evolved in the developing countries? And what are the major challenges for it in these countries?
Okay. Thank you, and thanks everybody. I think Jan and Ranjit did an excellent job of covering some of the challenges that fractionators face in their presentation. So I won't sort of duplicate what they've already said, but maybe just to sort of add on, in fact, to the tail end of what's just gone before. One of the first things that happened during the COVID pandemic was that the South African government restricted the export of PDMPs to other countries. And at the same time, the demand within the country actually escalated quite significantly. And of course, this was against the backdrop of reduced plasma collections or whole blood collections as well. So it really did constrain us. But in terms of the development of capability, normally when events similar to this or within a country occur, everybody says we must have our own fractionation plant. And that's normally the first point they make. And unfortunately, it's a very important point, but it's not, it shouldn't be the first or the main one. So I think what we've heard so far is that the provision of PDMPs is a whole process. So we've heard quite a lot about supply volume, that there has to be an adequate plasma volume to make it viable to have a plasma fractionation plant. And one of the figures that Jan put up has been a long-held belief that as long as you've got 300,000 litres to fractionate, that's a viable volume. I would actually question that that figure has actually escalated closer to 500,000 litres now, and most fractionators aim to be around that kind of level in order to make it viable. And then, of course, if you don't have that kind of volume, then what do you do? And we've touched on the subject of toll manufacturing and possibly even regional manufacturing. So where you could end up with a regional center that could draw from what currently I hear are sort of less than ideal sort of collection volumes, but they could possibly, if there's cooperation between countries, they could actually be drawn into one central area, as I've seen on certain continents where they're trying to establish cooperation schemes where they establish a fractionation plant but draw from many countries within that region. So that's one way of overcoming the limitations of the available volume. But volume is just one characteristic. And again, a point that was well made was that the need for quality of the plasma is in fact one of the major considerations. So quite often you hear of countries saying they have a volume of plasma available, but unfortunately it's not of sufficient quality. Their GMP procedures are not adequate. So even if you're thinking of going down a toll manufacturer or down the manufacturing for yourself, you still have to have an incredibly strong quality system that includes auditing not only from an internal process, but also to externally evaluate collection centers, whether they be blood services or plasma services. And then a point that Jan made, and in fact Ranjit as well, is the kind of funding that is necessary for a developing country to build even a normal pharmaceutical facility is not inconsequential. And so a basic fractionation plant that just looks at fractionation, refining, down to perhaps fill and finish, will probably cost somewhere between 100 and 150 million US dollars, just to sort of get you started. And then that very important point that was sort of bold and underlined in Jan's presentation about training. We found, and don't forget, we are a fractionator in a developing country, the training is critical to the success. And the other thing that is critical to success is having the kind of determination and dedication of individuals in making these things happen. We found that quite often these schemes actually fall over when they're given to committees to run. You actually need a core dedicated team that can actually evaluate and then hopefully roll out these kind of things. And then perhaps sort of, and maybe a point that I could finish on, is often you need, because the technology is not available within the country, you need a tech transfer partner. And then you have to consider what kind of manufacturing technology is available to you, because the latest tech may not be the most suitable option to pursue. It may be because of the cost of that tech package itself, or the high operating costs, or even the techniques themselves may be so complex that it's difficult to do, and they were developed for a specific purpose in their originating country, which may actually not be relevant. And in MBI's case, when we engaged in tech transfer many years ago, developing our products, the very next thing we had to do was to develop our products so that they were suitable for our environment. So we made sure that they were all the PDMPs could be stored at room temperature, for example. And obviously there's always the battle between purity and yield and just having a robust product. So often it is a mixture of evolution and growth. And so when you come to facility design, you may have to go for a modular design to start to accumulate and allow time for the plasma to be identified to feed the monster you're creating. And so there's often stages that one goes through where you start with a more modest design, but with a future development of, let's say, 1 million liters or so in mind, but you may well start at 200,000 or 300,000. You can probably guess I can talk forever on this subject, but maybe I should draw to a close.
True. So thank you so much for reiterating those points that were brought up by Dr. Ranjit and Kalyan also. And it's nice to hear, because we are basically transfusion medicine specialists. We all. It's nice to hear from you, people who are into the plasma fractionation day in and out, and to hear these points from you. And these are learning lessons for all of us. And thank you so much for that. And can I see Manita? Is Manita around? I suppose she has not joined. I can't see her, yes. So now my next question again, can I ask Matthews that what is the option of regional versus country-wise self-sufficiency, and what limitations do you see for each of these options? Option of regional versus country-wise self-sufficiency, though you did speak about it, and but still, what limitations do you see for each of these options?
Yeah, the first limitation I would see would be actually regulatory in most countries. Specifically in Asia, we talk about, as you already mentioned, the lack of plasmapheresis for fractionation in India. In other countries, in Vietnam, I don't know if anyone from Vietnam's here, but they don't even have the proper regulations to collect recovered or source plasma for fractionation. So these laws and regulations have to be defined within the governments, within the systems, so that either contract fractionation or even independent fractionation plants can be built. Until then, nothing can be done in those countries. But of course, some countries do have regulations that are already suitable for use, and then it's a choice. Do they want to have government funding, public collection of plasma, which of course would be government funding, would be taxpayer funding, or do they want to invite the private sector, which comes with its own money for profit reasons, to try to collect plasma? I think we've seen in Asia, in China, yes, there's the private companies, but outside of China, there really isn't any. So no country has wanted to move to that path. Of course, the US has that. Europe mostly doesn't have private companies collecting plasma, but in a couple countries it does, as we saw Jan was mentioning some of that data. Latin America, there isn't either, or Middle East. So it's really most countries have decided to go public resources collecting the plasma for this system. But then of course you always have the challenge of budgets within governments and how much money is going to be allocated, and usually not enough, and so they're not self-sufficient.
And the government allocations are very difficult in our Asian countries. It becomes like for us also in India, though we have the fractionation centers, but then private sector plays a big role, and there are people, means we have fractionation centers from the private sector as well. And I would like to ask Dr. Tegu the same question again, that because Indonesia, I understand, right now is into the phase of bringing up a fractionation center, but it does not have itself right now. So how do you manage, and what are the contracts, these fractionation programs that you have with the other countries right now with you? And how does that help you out?
Yeah, thank you, Dr. Sangeeta. That as you said, and also Matthew said, that sometimes it is difficult for countries like Indonesia to give funding for this program, national program. So we know that Indonesia, as far as I know, would like to open also this program not only for the government but also for the private sector, as far as I know. So we are thinking to firstly to implement the what is it, contract fractionation program, but in while we like to prepare or preparing many resources to make our own national fractionation program. So we think that it is my own opinion that I think it is wise to open it for not only for the government but also for the private, whoever can manage this program for national program. And also the other challenges, I think, in my opinion, is the most is how to fulfill the need of this resource plasma, or the plasma not only from, we know that it is not enough just only depend on the recovered plasma, because recently we have about 19 blood establishments in a country which are already certified by Indonesian FDA, and we should increase the number of blood establishment to get the certification from Indonesian FDA to make or to prepare our plasma for fractionation. So this is also our problem. So we are thinking that how does the source plasma? So because we are now thinking that the recovered plasma is not enough to fulfill or to supply all of the need of the plasma fractionation in the country.
Yeah, thank you so much for that. And there is an extempore question for Dr. Ranjit, that though he's not in the panel, but I definitely would like to put this question to him, because Ranjit has been very instrumental in our country in bringing up with the fractionation program. And he is right now working a lot on it. And Dr. Ranjit, I would like to ask you that government funding is definitely a problem in our country and in the surrounding countries also. It's not only the question of India, it's the surrounding countries. So what would be your suggestions for even the surrounding countries, that how do they come up with fractionation, or are you planning to be as a private, play a role as a private sector to means help them in the fractionation of plasma for their countries as well?
Yeah, thank you, Sangeeta. I think the question is very valid question. And if you look, I have worked in private sector, government sector, various advisory positions. And my assessment is that the government should really govern the system, not run the system. Because the moment
True.
government starts running the system, they do not understand the intricacies of the business of plasma. And this is a business of what Matthew or David or Ian has mentioned. It's a very, very complex, very competitive, and a very, very demanding business, quote unquote. And we are talking of the business. We are not talking of a charitable institutions. And it brings a lot of challenge. So that's the one part of it. Having said that, we India, I mean, we had the World Bank grant to set up the fractionation plant in 2007 and 8. Unfortunately, it hasn't seen the light of the day as I'm talking to you, despite fund allocation. So it's not only the money which drives the entire agenda, it also needs a high political will to execute and work on it. And unfortunately, in most of the government setup, the government changes every 2 years, 5 years. The people have position of authority, they change. Once they change, their agenda changes. So it does not leave any commitment. And if you look the global scenario, wherever the plasma fractionation program has done well, either in the public sector or in the private sector. Private sector has evolved very well even on the plasma collection. But within the public sector, if you see, there has been a stability factor which has played a very important role, which hasn't changed from government to government and so on and so forth. And to the last part to say, I would suggest that at least in this part of the world, Southeast Asian countries, they must look at the lesson what we have done, Sangeeta. There is not a single government plasma fractionation plant, right? And it is all private player. And when I started my work, there was none. And there was not 1 liter plasma collection program. So what we have done, I mean, I remember my early days of delivering lecture, like 100 lecture per year, going to the various blood bank, talking to the ministers, and eventually pave the road. I think all the countries, nothing comes that easy. And I think if they are able to bring that commitment on the table with this forum, and where, I'm sure people like Matthew or Ian or David would be more than happy to offer all possible help to pave the road for these programs. So I think we can take help of people who can help us in paving the road, but it is something like this, you're running a marathon, you have to run. Eventually they can give you a glass of water or, or a bottle of energy drink, but eventually you have to run. So countries have to run. These guys are there to help you out. I'm talking on behalf of Matthew, David, and everyone. I hope they will agree to it.
They agree more than they agree, yes, of course. And that's so true that the ones who have to achieve, the ones who have to reach the finishing line for a marathon have to run themselves. So that's so true. I mean, support can come from all around, but the running has to be done by the person. So my next question goes to David. Do you see it a requirement, though I had asked it earlier also, to implement these plasmapheresis program to collect the raw material rather than just depending on the whole blood collections? Do you see that as a program coming up, that should it be implemented as a plasmapheresis program?
Yeah, I think it's inevitable that it will. And the only thing I would say is that it shouldn't be in competition. So you're looking to attract more donors rather than converting donors. And often there's a conflict that exists where you have an existing blood donor who then is just attracted sort of further down the road to donate plasma. Meanwhile, their blood is as valuable, if not more valuable in that process. But certainly you need both. You can't have just recovered plasma, and you can't have just plasma donors. I think you need both.
Yeah, thank you so much. And though I want to continue this, but I'm getting signals for that the time has exceeded a lot, and there are many questions to be asked. And this forum is actually a wonderful forum to get the answers that we all had with the questions and that we had in our minds to get the answers. A real good forum to get those answers, but still, because it's getting late, so I would really like to stop here and thank all my panelists who were here and gave such excellent insight into the plasma fractionation and how it has to be improved, and learned a lot about how it has to be mapped, evaluate the availability of the plasma and the safety profile, how we have to go forward. We learned a lot about it today. And I really thank all my panelists. And now I hand over to our very dynamic Secretary General of ATOM, Dr. Anand Gunasekara, who again is a personality whom you have to learn so much from. And I hand over to him to give the vote of thanks. Over to Dr. Anand.
Thank you, Dr. Sangeeta. Thank you very much for those endearing words. It's indeed a great pleasure to deliver this vote of thanks, and thanks the organizers for selecting me to do so. Not only as the Secretary General of ATM, I'm also the chairperson of this plasma protein therapy group of ATM. That is among the other 10, 12 effective groups in the ATM, and we are also equally effective like them. So my first thanks goes to Dr. Jan M. Butt of USA for delivering the keynote address. Dr. Jan, I know it's a bad time for you, but you kept us alive with that fantastic lecture with the facts. And we were alive and you were alive. Thank you very much, Dr. Jan, once again. And next, my thanks goes to Dr. Ranjit Sajmani of India and Dr. Kalyan Roy of Bangladesh for giving the country status in India and Bangladesh, respectively. Next, the elite group of panelists. Mr. David Stubbings of South Africa, Dr. Matthew Hotchko of USA, Dr. Teguh Triano of Indonesia, for contributing very, very effectively and academically. And thank you very much for all of you. Dr. Varma, Anju Varma, who did the coordination and chairing the session very, very academically and technically. Thank you very much. And it's, of course, our Iron Lady, Dr. Sangeeta Pathak, for moderating this session very, very effectively. Thank you, Sangeeta, for that. I also thank all the participants. We had a very good group of people today join from many countries, and I thank all of them for joining us. That gave a lot of encouragement for us. And I also thank the President of ATM and the Governing Council for allowing us this kind of activities through the groups, working groups, and which is going on very well. So it's all in all very good, and thank you very much. And we hope to do more of these things in time to come. And one little suggestion or a word I can give as a professional organization, we as a professional transfusion organization, taking into the discussions and the conclusion all taken place in this program, we can give a good helping hand to the fractionation programs. All the countries cannot do it due to reasons that we have discussed, but let few countries do it, those who have good system, and let us help to channel, source the plasma into those countries and share share the products. With that, thank you very much, and back to you, Dr. Sangeeta.
So thank you all, and it was such a pleasure to have you all and share the screen with all of you. And I'm taking a screenshot, so all of you should smile at me back. I'm taking a good screenshot, okay? That's it. Thank you so much. Dr. Jan was, wait, I have to take